right, good morning everybody. So in this session I'm going to briefly go over ECG interpretation. So I'm trying to keep it to simple for year 2 level because we are going to have an extended discussion of ECG interpretation in year 4. So ECG is actually a very vast subject. It's not medicine, it's physics. All right. So you can do a PhD on ECG. It's that much of a big subject. Okay. So if you become a cardiologist, you will know about 20% of ECG. All right. By the end of year 4, so after doing so much of ECG, actually in year 4 we offer you 10% marks for your on-course assessment for ECG. Then after that you might know about maybe 8% of ECG. All right. So in year 2 level, it's pretty much like you will know 1 or 2% of all the ECG content. All right, really simple. But I'm going to discuss its clinical aspect. So when you guys do your rural placements, you might come across with patients with various cardiac problems, and you might see various ECGs. So it's better try to interpret the simple ECG. So sometimes you might get your help from your supervisors as well. All right. So these actually. A little bit of a addition to Lisa's week 2, 3, 4 content, okay? And I think you have done hypertension last week, and this week have you done ischemic heart disease yet? Yeah, just tomorrow. Yeah, so those things are a combination of the things, okay? Now these are the stuff which we discussed last couple of weeks. Now structure of the heart, actually it's mainly composed of 2 types of cells, conductive cells and contractile cells. So we know conductive cells, it has a special ability, that's the automaticity, and they're actually firing in various rates. So SA node, AV node, Purkinje fibers, they all got their inert firing capacity. SA node is the normal pacemaker if your heart is normal, and it has the highest firing rate. We know how the autonomic nervous system controls this. So parasympathetic, sympathetic, its balance actually keeps this rate to that level. Okay. Now this actually one system is a backup system to the other one. So if your patient's SA node is not working properly, or if it's stopped, heart won't stop. Actually the AV node will take over, and the ventricles will contract and its pumping action will go on. Okay. If SA node and AV node both fails, actually Purkinje fibers will fire. Okay, like that. Now what will happen, SA node, AV node and the Purkinje fibers, if everything is dead, what will happen? So do you think the patient is dead? No, because one of the ventricles muscle will take over and it will start to fire. All right. So electrical wise, it's very difficult to kill a heart. So it has a very good backup system, and actually a backup to the backup system as well. All right. Then once you get the electrical impulse to the myocardial cells, it actually behaves as an electrical syncytium. So the muscles contracts together. All right. So those are the two types of cells. Then this is our conducting system. So year 1 to 3 in basic sciences, this is the conducting system. All right. So later we will learn what's its actual form. It's a little bit different to this. Okay. So we have the SA node, AV node. Then we got bundle of His and the Purkinje fibers, left bundle branch and the right bundle branch. So that's the basic structure. Now this diagram actually shows how the ECG waveform generates. So we know initial firing comes from the SA node, and it depolarizes atria, and actually P wave represented that. Then electrical impulse passes through the AV node through the interventricular septum, and it depolarizes the ventricles. Okay, ventricular depolarization will be represented by the QRS waveform. Then ventricles repolarizes, it will be drawn by the T wave. Okay, so that's the classic ECG waveform, PQRST complex. Now, if you look at your ECG tracing, which you recorded by your patient today, you will notice different ECG, different electrodes, actually they produce different pattern of ECG waveforms. Some of them got a good positive wave, some of them got negative waves, some of them are big amplitudes, some of them are small amplitudes. They all are dependent on where the electrode in relation to heart. Some of the electrodes are a little bit far away. Some of the electrical leads are actually right angle to the electrical axis. So that's why they all generate different shapes. Okay. So we'll discuss that one in a minute. So there are a few things we need to remember. So we already discussed P, QRS and the T waveform. Now PR interval is something we need to remember. Its usually duration is about 3 to 5 small squares, so 0.1 to 2.2 seconds the duration. So it's actually beginning of the P wave to the beginning of the QRS complex. That's the PR interval. It represents the time taken from the electrical activity to pass from SA node to AV node. Okay. Then RR interval is important because this is the one which we are going to use to calculate heart rate on your rhythm strip. We are going to count how many big squares and we are going to use a simple calculation so you can get the rate. Okay. QT interval is important clinically, but we are not going to discuss it today. Okay, it's associated with some diseases we will discuss later. Then ST segment is important. ST segment, if your heart is normal, is in isoelectric, so it's a 0 voltage. But if your patient is experiencing ischemia, depending on the type of the ischemia, it can fluctuate. It can elevate or it can go down. All right. All right. Now we put everything together. We can get the 12-lead ECG graph like this. Now you can see this side. You can see the standard leads 1, 2, 3. Then you get the limb leads. Then you have chest leads V1 to V6. So those are the 12 leads, and the 13th one actually. The same thing like that, lead 2. All right. Now in a minute I will explain why we select lead 2 as the rhythm stream. Okay. Now to understand how various electrodes generate various patterns of ECG waveform, we need to understand how we position electrodes around the heart. Okay. If you carefully analyze, actually you will notice we arrange these electrodes in 2 different planes, in a vertical plane and in a horizontal plane. Okay, so I'll draw a picture on the board, so it's much more easier for you to understand. Then, if you can't see the board, you might move into the corner. Can you see the board? Can you? Yeah, you can see the board, isn't it? All right. All right. So we know our SA node, AV node, then bundle of His, and then the right and the left bundle branch. So that's the basic conducting system. Now, first we attached chest leads. Or electrodes V1 to V6. So we attach them right across the heart like that. So V1 to V6. So they all are gathering electrical activity which happens right across the chest, mainly in a horizontal plane, this plane. So this is how we attach those leads across the heart. All right. Now, then we attach certain electrodes to right arm, left arm, and the left leg as well. Okay, so those things are actually, first we'll consider right arm AVR, AVL, and AVF. So they actually gather electrical activity which happens in our vertical plane, this plane. So this is the plane. All right. So they get electrical activity in these directions. All right. Then we need another 3 electrodes. That's actually electrical directions coming from the Einstein triangle. All right. Now Einstein triangle, actually what they describe is the voltage differences and the directions of the electricity from right arm to left arm, then left arm to left leg, and right arm to left leg. So this is the triangle. So direction of the electricity is, if I mark, this is how: right arm to left arm to left leg, and right arm to left leg. So those are the directions. Okay. Now we know this one is lead 1, this one is lead 2, and this is lead 3. Alright, so there's a little bit of an easy system for you to remember, because sometimes you might get confused which one is lead 1, which one is lead 3. So you can see, you can link these L letters with numbers. Single letter to lead 1, 2 letters to lead 2, alright, then 3 letters to lead 3. Right? Because we have lots of stuff to remember, so it's better to use shortcuts a little bit. Alright? So those are the reasons. Now to apply Einstein triangle onto the heart, actually you can't use this triangle exactly the same way, but what we are going to do is we are going to disintegrate the triangle, but at the same time we have to keep the direction of the electricity in the same way. Alright? So we'll take the lead 1, so its electrical direction is that way, right arm to left arm. That. Alright. Then lead 2, its direction is that way. Alright. And lead 3 is coming the other way. Alright, now we have the rest of the 6 leads now. They all are in your vertical plane. Alright. Now, did you all understand this one? So this is the basis of ECG. How various electrodes position around the heart in 2 different planes, vertical and the horizontal plane. Okay. Now, when it comes to clinical application, we'll consider example. We'll assume you guys are doing a rural placement in somewhere, maybe Atherton or somewhere, all right, and you've got a patient with a chest pain. So you did a ECG, and doctor looked at the ECG and he comments, this patient got an inferior infarction. All right. Now, to do that comment, actually doctor needs to look at the inferior leads. That means the leads which are facing towards the inferior part of the heart, or the leads which are gathering electrical activity of the inferior part of the diaphragmatic surface of the heart. Now, if this patient is experiencing inferior infarction, this is the inferior part of the heart. So the leads which are facing to the inferior surface are lead 2, 3 and AVF. Alright. So when it comes to ECG interpretation, what we do is, rather trying to analyze each and every lead, we actually populate lead combinations and we try to identify what leads are looking at what surface. So if you think patient got an inferior infarction, patient should show some changes, significant changes on the inferior leads. Now we know what are the inferior leads. So they are the ones lead 2, 3 and the AVF. Okay. Now if this patient is experiencing anterior pathology, anterior wall pathology, these are the leads which are gathering electrical activity of the anterior part of the heart. V1, V2, V3, V4. Anterior surface, and also they gather information from the septum as well, because we know interventricular septum is just under your anterior surface of the heart. So if there's something happened in the interventricular septum, it will be represented by one of these leads. Okay. So the relevant changes will be shown on V1 to V4. Now actually V5 and V6, they gather abnormalities of the left ventricle lateral inferior wall around that area. Okay? And lead 1 and AVL gather electrical activity which happens around this area. That's the lateral upper wall abnormalities. All right. So in year 2 level ischemias, mainly we are discussing left ventricular ischemias, and mainly we discuss either inferior, anterior or lateral. All right. So in year 2 level, we don't much discuss about right ventricular ischemias or posterior ischemias. They will discuss those things in advanced years. Okay. Understood this one? You guys need to remember this one. This is the, as I mentioned earlier, this is the basis of ECG. Okay. So I'll put everything into a summary. So this slide shows the summary which I discussed right now. So you can see the 2, 3 and AVF represents the inferior surface of the left ventricle, and lead 1, 2, 3, 4 mainly anterior wall and the interventricular septum. V5, 6 lateral aspect inferior, lead 1 AVL lateral aspect superior aspect. Okay. Now AVR, we don't much bother about the AVR at year 2 level, but it's written on there. Because of that, I'll briefly comment. See, AVR is gathering electricity which are coming towards that way. That means they need to come from somewhere here. All right. So if your patient got a left ventricular subendocardial problem, it will be shown by this one because it's directly facing towards the endocardium of the left ventricle. Okay. This for just your information only, because this is a little bit of a complicated area. We are not going to go into greater detail of that one. Okay. Yep.
What's the difference between lead 2 and AVR?
They're in completely 2 different directions.
Yeah, so
all right.
Can you also get the left ventricular subendocardial activity from lead 2 as well?
You can get the lead 2, but the thing is, we'll come to that in a minute, because depending on the type of the ischemia, the direction of the electricity changes.
Right.
All right. So in a minute, I'll describe that. Okay. Good. Now, we know normal electrical axis. We discuss always normal electrical axis is towards lead 2. All right. So that way. So this is the normal electrical activity, or the summation of the electrical activity. All right. So I mentioned usually rhythm strip is the lead 2. We choose lead 2 as the rhythm strip because of this, because mainly current, or the summation of the current mainly heading towards lead 2. Because of that, it produces the best waveform. Okay. So one of the ECG laws is, if electricity is directing towards a particular lead, it produces the best or the positive waves. So if you look at your ECG, if your patient's heart is normal in lead 2, it should produce all the positive waves, P wave, a good R wave and a positive T wave. All right. Now, who is on the other side? AVR is on the other side. Okay. Now, all the electricity, mainly they are directing away from AVR. So AVR should show all negative waves. So on your ECG, if your patient's heart is normal, you will see patient will show negative P wave, mainly deep S waves, and negative T wave. That's because AVR doesn't receive much electricity. Now, positioning electrodes around the heart is like positioning telecameras around a 40 oval. All right. Single event happens and the 12 telecameras telecast them in 12 different ways. If the player kicks to a goal, the telecamera next to the goal will see the ball is coming towards them, and it will show a big ball directly towards the camera. That's the way the lead 2 will show a big wave. on that side. So the camera next to the other ball will see the ball is going away, and they will show a small picture of the ball. The same phenomenon here. All right. The same event will be telecasted or will be drawn in different ways. Got it? All right. Now, when it comes to ECG interpretation, we have to consider 15 points. All right. Now, year two level, we are not going to go through all the 15 points. This one point is one chapter, in the ECG book. So, we are going to discuss only the first 4 mainly, and going to go over P wave a little bit. So, calibration, rate, rhythm, and axis, and a little bit of P wave. That's enough for year 2 level. Okay. All the others and their associated pathologies will be discussed in year 4. All right, calibration. So if you are calibrated normally, the voltage should be 10 millimeters per millivolt, and your ECG paper should run 25 millimeters per second speed. That's the normal calibration. On your ECG graph, actually it needs to show height of 2 big boxes, like a rectangular square on left hand side or on the right hand side. It's a one bigger square in width. So that's this is the one here. So they have calibrated in the normal way. Okay. Calibration is actually important because sometimes some patients, they don't produce good ECG waves. So on the paper you will see very rudimentary ECG complexes. Their voltage is so low, actually you can't pick up any pathologies. Say for example, your patient is an obese patient or chronic smoker with COPD or asthma patient, or if the patient got a pericardial effusion or something, they don't receive much electricity onto the surface. Because of that, the ECG graph will be very poor with the small complexes. Then for the interpretation, actually you need to create a bigger wave. So what you do is you will increase the calibration. You will make it to double the size of the waveform. Okay. The important thing is next time for the next patient, if you use the same machine without recalibrating, that patient might show big waves. So if you think you have calibrated normally, you will interpret that patient's wave in a wrong way. So you might see that patient got a bigger ventricular enlargement or something. Actually the patient's heart is normal. So that's why always we need to check the calibration. Okay. Then how do we calculate rate? Now before calculate the rate, actually you have to check the rhythm strip and see whether the patients show regular rhythm or a rhythm is irregular. If the rhythm is regular, that means all the RR intervals are similar, then you can use the first calculation technique. That's you will divide 300 by number of bigger squares between RR. Okay. Then if the rhythm is irregular, that means if your patient is experiencing atrial fibrillation or sinus arrhythmia or something, then you can't use the first method. Then you will count number of big squares within 50 big boxes, and then you will multiply it by 6. All right. Now I know Lisa taught you another technique as well, but in exams you can use any of those calculation methods. Okay, because in the answer I usually write a range. I consider Lisa's calculation methods, my method, and there are a couple other methods as well because different students use different techniques. Okay, so there's a slight variation, but if you use one of those acceptable calculation techniques, then you should get marks. All right, rhythm, sinus rhythm. Now, to define rhythm as sinus, patient needs to fulfill the following criteria. SA node should be the pacemaker of the heart. Now, if the SA node is the pacemaker of the heart, the electricity is traveling towards lead 2, so that means P wave of the lead 2 should be positive, and the P wave of the AVR should be negative. Okay, so that's the other criteria, and each P wave is followed by a QRS complex, and the PR interval in a given lead should be constant. So if all these criteria are fulfilled, then you can see patient is in sinus rhythm. Okay. Sometimes when you look at the ECG's rhythm strip, actually you might see it looks like sinus rhythm, but when you apply this criteria, the patient is not in sinus rhythm. Okay, so you have to look carefully. All right, axis. Now we briefly mentioned normal electrical axis is directing towards lead 2. So that means this way. So your heart's electrical activity is going that way, mainly towards apex. All right. So left axis means if this axis is moving towards your left hand side, so that's the left axis deviation. It could be due to physical rotation of the heart. Say for example, if your patient is a pregnant mother or patient with a bigger liver or intra-abdominal pathology, this pressure can cause a deviation of the hearts. Actually physically heart is rotating, then actually the axis changes. Or sometimes what happens is patient's left ventricle is getting bigger, could be dilated or could be hypertrophied, then main electrical activity deviates to that side. Okay, so that means in those situations, actually summation of the electricity, instead of going to lead 2, now it's going to lead 1. So lead 1 will draw the lead 2's picture, and the best waveform will come to lead 1. So when you look at the ECG's lead 1, 2, 3, you will see all the tall R waves are now in lead 1. All right? And now when this axis rotates that way, the opposite side lead will be lead 3. And it will show deeper S waves because it's on the other side. Electricity goes that way now. Okay? So, so when you look at the ECG and if you see this sort of a picture with the bigger R waves in lead 1 and the deeper S waves in lead 3, then you will say the patient got left axis deviation. Okay. Here we have given a couple of common examples for left axis deviation. Now exactly opposite happens when the axis changes. If it's the right axis deviation, so this is the normal axis, so the axis deviates this way to your right hand side. So that means this one comes this way. Now the lead 2 diagram will be drawn by lead 3 and the opposite lead will be lead 1, and they will show this sort of a picture on your ECG. So lead 1 will be the deep S waves and lead 3 will produce the tall R waves. All right, couple examples are given here. Remember, we don't ask you to calculate these degrees. It's a different formula and we don't ask, but if you can understand what does it mean by the axis and what is right axis deviation, what is left axis deviation, what actually happens, then that's enough. And we have given one method in your notes, ECG notes, easy way to work it out. But remember, there are 5 or 6 different ways. Different doctors use different techniques of analyzing axis, but the final answer should be the same. Okay, but this is what actually happens in the heart in axis deviation. All right, P wave. Now we know P wave represents the atrial depolarization. Okay, normal P wave size is about 3 small squares in width, 3 small squares in height. So it's a semi-dome shape. Okay, now it's actually height and the width changes with the abnormalities of the atria. Sometimes you might get right atria enlarged, bigger right atria. Okay, then actually you will see the P wave is like very peaking, like tent shape, so which is given in diagram A. Okay, one of the examples or pathologies associated with atrial enlargement is could be tricuspid stenosis. So if patient got a narrowing of the tricuspid valve, the patient can't push right atria blood, all the blood into the right ventricle. Okay, so then the back pressure develops, so accumulation of the blood happens in the right atria and it's getting bigger. Or sometimes the patient can have tricuspid regurgitation. So that means tricuspid valve is not closing properly. Okay, So every time when the right ventricle contracts, some of the blood actually going back into the right atrium. Okay, again patient will be ended up with the right atrial enlargement. Okay, and on the ECG they will show peak P waves like the way given in the A diagram. Then the same sort of a pathology can happen on the left atria as well. I think in RIT you have discussed about the rheumatic valvular disease, isn't it? Rheumatic heart disease. Yeah, so mitral valve is very vulnerable in rheumatic heart disease. So sometimes it could be ended up with mitral stenosis or mitral regurgitation. In both cases, left atria will be enlarged and ended up with left atrial hypertrophy. So in that case, actually, you will see the atria produce like a M-shaped wave, okay, with two humps. So this is a characteristic waveform for left atrial enlargement. Okay, so by looking at the configuration of the P wave, you can comment whether there's any sort of a atrial pathology or not, or whether it's a left or the right atrial pathology. Okay. ST segment. Now usually ST segment is isoelectric, so it's at the baseline if the patient's heart is normal. Okay. If the patient is experiencing ischemia, this can go up and down depending on the type of ischemia. All right. Now, so we'll briefly discuss how ST segment changes in subendocardial and transmural infarctions. Now, if you can remember the anatomy of the heart, especially coronary arteries, we know coronary arteries are surface arteries. So they are actually on the surface of the heart like that. All right, because they can't be buried in the muscles, because when the ventricles contract, they might get squashed, and the heart muscle won't get blood. Okay, so that's why they sit on the surface, and they actually provide nutrients and oxygen right across the myocardium that way, from epicardium to the endocardium. So that's the direction. Okay, now sorry. If this patient got a coronary artery obstruction, partial obstruction, you will see the most distal cells will suffer first. That's the endocardium will get the problem. All right, and patient will experience subendocardial ischemia like that. All these areas are working perfectly well, but this area is now started to die. Okay. Now, when the patients are experiencing subendocardial ischemias, actually this area doesn't allow this electricity to travel through the muscle. So the electrodes which are situated next to them will not get electricity over that one, because what happens is this surface actually bounces all the electricity backwards. And now we can remember the first ECG law. If a electrode receives electricity, it will produce positive waves. If it doesn't receive, it will produce negative waves. So in this case, these leads which are next to the subendocardial infarction will not receive electricity. Because of that, they will produce the ST depressions. Okay, so which will shown in this diagram. You can see here, this patient is experiencing a subendocardial infarction. The electrode next to that is a V5. So it will produce the ST depression wave. Okay. This diagram shows a full thickness infarction. Now, if you left the patient like that, eventually the patient will get a complete obstruction of the coronary artery, and this whole area will get infarcted. So the full thickness infarctions, actually electrical activity behavior, it's different to the subendocardial. Actually this area accumulates electricity, and the electrodes next to that area will receive lots of electricity like that. Then when you apply the ECG law, the leads which are getting more electricity will produce a bigger waves. So the same thing happens here, they will produce a bigger ST. All right. So in clinical applications, this is how we are going to apply this one. So when you look at the ECG, if you notice the patient got a ST depressions in various areas, then you can straight away say this patient got a subendocardial ischemia because patient shows ST depressions. Then you will say which leads patient show ST depressions. If the patient shows ST depressions in lead 2, 3 and AVF, 2, 3 and AVF, patient should experiencing a ischemia subendocardial in the inferior parts. Alright. If the patient shows ST elevations in 2, 3 and AVF, then you will say this patient got an inferior infarction, it should be a full thickness because patient got a ST elevations. Alright. The same principle you can apply to the anterior walls as well. So if you notice sort of ST changes, then you have to look which leads patient show ST elevations, whether they are anterior leads, inferior leads or the lateral leads. Then you can exactly say what area of the heart got affected, and if you can remember the coronary artery anatomy, actually you can work out and say which coronary artery get obstructed, because we know different coronary arteries supply to the different areas of the heart. Okay, so you can precisely direct the patient to the cardiologist, saying that I'm thinking this is the coronary artery get obstructed, so you can do an angiogram to confirm. Got it? All right. This example shows a patient who is experiencing a extensive anterior infarction. We add the extra word extensive if patient shows ST elevations V1 to V5 or V1 to V6. So that means the whole anterior part up to the lateral walls got infarcted. Okay, so you can see actually this patient was experiencing chest pain right in front of us in the board. So this is the acute stage. You can see all the ST segments are very elevated, but after about a couple hours you can see still ST elevated, but the shape of the ST elevation is now changing. Okay, and now for year 2 level, just a ST elevation, this shape is enough for you to remember. All right, but just for your information, ST elevation is actually the shape changes with time. Okay, so if your patient is experiencing ischemia right in front of you, the shape will be like that. But if the patient experienced chest pain about 24 hours ago, the shape is different. Okay. Later we are going to teach those changes. Then actually you can exactly say when the patient got the chest pain. So you can say whether it's 18 hours back or 24 hours back or 48 hours back by looking at the shape of the wave. Or whether the patient got this problem 3 months back. All right. So then the wave shape is different. Okay. All right. Now this example, the diagram A shows actually this patient complains on and off chest pain. So what we did was we did the treadmill test. We attached the patient to the monitor and we asked the patient to run on the treadmill. And patient started to get chest pain. All right. And ECG monitor showed ST depressions. So now we know ST depressions happens when the patient gets a subendocardial ischemia. So that means patient was experiencing a subendocardial ischemia. The changes are indicated in diagram A. Then we stopped the treadmill and we treated the patient with sublingual TNT. That's a treatment we give for acute ischemia. So it helps to increase the coronary artery circulation. And patient got relieved pain and patient improved. And we noticed the ST segment came back, the ECG turned back to normal. Okay. All right, a couple abnormal rhythms. I think Lisa discussed about 5, maybe 7, 8 abnormal rhythms. I think she discussed about some blocks as well, isn't it? Yeah. First degree, second degree, and various blocks as well. All right. So this one shows atrial flutter. The first diagram shows non-controlled. So atrial flutter is actually this is the firing rate in atria. But all this electrical activity can't enter into the ventricles because the AV node got a filtering system. It doesn't allow more than 200 to pass through. So that's why rate is limited to 150. So this is the pathology. Actually, there's got a spinning electrical activity above the AV node. And now this diagram actually shows the controlled the atrial flutter pattern. So it shows the characteristic sawtooth appearance. So this patient must be on treatment, and actually treatment increase the AV nodal resistance, and it filters most of the electricity. That's why the rate came to somewhere around 75. All right, so this is one of the other abnormal rhythms. This is a lethal rhythm, so this patient is about to enter into asystole, okay? So you have to use cardioversion or some sort of thing to reverse this back to normal rhythm. So you won't see this one in GP settings. Sometimes you might see in EDs or in cardiology units, okay? I think Lisa discussed this one as well. I think that's the basic interpretation lecture, okay? Do you have any questions? I think this is the basic stuff I think Lisa discussed as well, and ischemic heart disease component they will discuss tomorrow lecture. Then you will get a better understanding how the ST segment changes, how it goes up and down as well. All right. Okay, so if you don't have any questions now, we have a couple worksheets on your table. You might work through, and the laminated sheet got various abnormal ECG tracings with abnormal pathologies. So we will come around, and if you've got any questions, so we can clarify them. Thank you.
Is it because the ischemic cells repolarize faster? And so
Give me a sec, I'll switch off that one and come back. Otherwise, it's connected to the mic. All right, thanks. Yep.
I've got one. But if they don't have events, you don't get. Because I live near. You know when they had the Barbie and the. It's pretty.
Brady.
Myself.